And I start by asking if you remember the initial public announcements on the pandemic that asked young people to observe restrictions and give up some of their freedoms to save the lives of their grandparents. Now, to my mind, that immediately established COVID as a disease of older people. This was wrong, as we've since seen, given the average age of people infected in Australia is 37 years. But perhaps it also explains why some younger people acted as if they were immune, with the effect over time that more people of all ages are being infected and the long-term health consequences are only starting to be understood. But it's true that the majority of deaths in Victoria have been in residential aged care. There have been more than 800 COVID deaths of grandparents, mothers and fathers in aged care in Victoria alone. We now know that these facilities can provide the perfect conditions for a highly infectious virus. They are often under-resourced and poorly regulated, with a casual, poorly paid workforce, and in a sector which suffers from divided government responsibility and inadequate planning. Over the years, numerous public reviews have established the problems in the sector. The present Royal Commission has shown us how older people in aged care are being neglected and at times abused. But to date, addressing this problem has not been a priority for the community who vote or for the politicians we elect. Now that makes me wonder, does this suggest older people matter less to our community? If we were not an ageist society, would we tolerate this situation? That's why, for me, it was no surprise to see calls for cost-benefit analysis on the question of saving older lives at a time when there are limited resources and when the economic effects of lockdown on the lives of the community has been very, very difficult. We read that the Vice-Chancellor of Melbourne University suggests use of the quality adjusted life year model. That's a unit of measurement used by economists to predict and assess the impact of health policies for health services. He says it boils down to, and this is a direct quote, what is the value of a 90-year-old's life versus the value of the continuing livelihood and happiness of a 25-year-old. In a national newspaper, an economist suggests using the value of statistical life model. This places a dollar value on the worth society places on a year of life for an individual. In 2019, the value of a statistical life year was $213,000. So this also leads to a lower value for older people who have less life years ahead. So we perhaps initially don't see either suggestion as ageist because we see economic models as objective and neutral. And these economic models probably work well for the purpose for which they were designed. But we can't forget that economic models are built on subjective assumptions by individuals. There is firstly the assumption that the value of a human life can and should be measured in dollar terms, and that therefore the life of an older person is less valuable. Now, if I accepted that measure, I could also argue that, that the individual value is their potential productivity or dollar value in society. I could also argue that older persons who make up a large percentage of volunteers, for example, contribute a lot. That sector was worth $58.1 billion in 2019. Or their value, I could quote their value in childcare, which enables parents to work. But I just don't accept this model. Instead, I agree with the response from St Vincent's Health, which you may have also have read in the papers, which asserts the need for an ethical and moral basis the allocation of resources. It reminds us that if we start with economic measures for older people, these could equally be applied to other groups in the community. Persons with a chronic health problem or addiction, disabled persons or long-term unemployed. And my question is, do we want a society like that? I prefer the society described by the St. Vincent health ethicist, where doctors make decisions based on a range of factors, including the patient's wishes, possible alternative treatments, urgency of need, and likely benefits. In an ethical and moral society, we accept the equal worth of all members of the community. We make decisions which balance the welfare of all groups, guided also by basic human rights principles such as respect and dignity. And I hope that's the society we actually live in today in Australia. But today, if we see decisions that clearly value more highly those people of one sex or one race, we are able to recognise and call out sexism and racism. This awareness has taken years of public education and debate. When the lives of older people are judged to matter less than others, or when we hear stereotypes based on age for younger or older people, do we recognise and call out ageism? Not often, I think. I think we're still in the early stages of that awareness. So I encourage you all to value a community rich in diversity, where we can share and learn from the perspectives and experience of all members, including older people. So what can we do about the ageism that has become, more prominent throughout the pandemic?
I'll have to be quick. What I do know is my manager is registered.
Catherine, can you put your mute on, please?
I'm just in a meeting at the moment, but yeah, she is planning to register.
Catherine.
You can mute her, Amanda.
Yeah? Oh, I can too.
Yeah.
Sorry. Yep. Careful.
Okay. So what can we do about the ageism that's more, well, this is part of what we can do about it. We can listen to Marlene. I'd like to introduce you to our guest speaker today, Dr. Marlene Krasovitsky, Campaign Director, Older Australians with the Benevolent Society, TBS. Marlene oversees two major campaigns, the EveryAGE Counts Ageism campaign and the Fixed Pension Poverty campaign to reduce financial disadvantage for older Australians. EveryAGE Counts is a national long-term campaign to shift negative social norms and public discourse about getting older and about older people. So we should change the way we speak about older people by the end of this talk. The campaign aims to set the foundations for current and future generations to age well, mobilise a holistic political response to the opportunities presented for our ageing population, and reframe the experience of getting older. The campaign focuses on building a social movement, strengthening policy and research, building effective advocacy and political engagement, strategic communications and marketing, and addressing structural barriers caused by ageism. Marlene was formerly the Director of Willing to Work, the National Inquiry into Employment Discrimination against Older Australians and Australians with Disability with the Australian Human Rights Commission, the AHRC. She also worked as a Research Director with the AHRC's review into the treatment of women in the Australian Defence Force and subsequent cultural reform program. Marlene will speak to us today about ageism in the context of the pandemic and what action we can take. Just to remind you all to please leave your microphones on mute and ask any questions or comments in the chat section of the Zoom. Please join me in welcoming Marlene. Perhaps we can do a reaction up here like this. Clap. Okay.
Oh, that's lovely. Thank you, everybody, and thank you, Rhonda. I am so delighted to be here with you today representing the Every Age Counts campaign. Thank you to COTA Victoria for the opportunity to be here. It is wonderful to be with such good friends again. May I also acknowledge the traditional owners of the land on which we are virtually meeting today. I am on the lands of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging. And so to Every Age Counts. Well, Rhonda's given you a very good description of who we are and what we do. Our vision is a society where every person is valued, connected, respected, regardless of age and health status. So, first things first, what do we mean by ageism? This is important because it provides the lens through which I'm going to make my comments today. We define ageism as stereotyping, discrimination, and mistreatment based solely on age. And research tells us that ageism against older people comes from negative attitudes and beliefs about what it means to be and to get older. Now, chances are you've all heard the definition of ageism before, but today I ask you to pause and just reflect for a moment. What do you tell yourself about getting older? What does ageism mean to you? Where have you seen it? Maybe you've experienced it. What did it feel like? Have you seen ageism at the shops when older people are overlooked or invisible? Have you seen ageism at the doctor's surgery when a health professional talks past the older person at their carer or relative, or when their concern is brushed aside because after all, it's just a function of getting older? Is it when you've seen an older person being talked down to, talked at, or ignored, or spoken to as if they're
Christine.
Have you seen it in yourself when you've made decisions for an older person that may be in their best interest, but haven't really given them a chance to voice their wishes? Have you seen yourself or family members be overly protective, insisting that certain activities that the older relative wants to do are just too risky and to be avoided? Have you seen ageism when you've made a decision based on seeing a whole cohort of older people, residents, care recipients, voters as all the same? I am guilty on all counts. I have seen ageism in others and I have seen it in myself. And that's why we need to talk about it, make it explicit and challenge it together. Oh, well, you might say they're all just minor one-off things, right? Wrong. Think again. It's these sets of deeply negative norms and assumptions that are at the heart of our thinking, our behaviour, our policy settings and institutions. And because they are so endemic, pervasive, we hardly notice them until now. Ageism is not benign nor harmless, and it's a big problem. It impacts on our confidence, our quality of life, our job prospects, our health, our control over life decisions, and the way we are viewed by others and by society, which is reflected in policy decisions and institutional settings. It is ageism that treats all older people as if they're the same, despite the great diversity based on age, gender, cultural, linguistic background, sexual identity, and much, much more. Yet we see this homogenous view of older people play out again and again in cultural stereotypes, media images, policies, program delivery, and even in research methodologies. The mission of Every Age Counts has not changed during this pandemic. We continue to advocate to ensure that older people's rights are protected and not eroded in these difficult times. Our foundational commitment is simple and holds steady. Every life is equal. Every human deserves respect and equal access to the right care, regardless of their age or health or ability status. We reject any argument or suggestion that any life is expendable or inherently more valuable than another. It is no more acceptable or less tragic for an older person to die from COVID-19 than it is for anyone else. During this crisis, we need, as individuals and as a society, to work together and hold on to our morals and ethics that value any and all life. It is in all our interests to do this. Intergenerational solidarity between young and old has never been more important, and we're seeing many great examples of people of all ages reaching out across the generations. This solidarity is crucial to get through the crisis and recover even stronger. So what are the ways in which we've seen ageism emerge during this pandemic? Well, during the pandemic, we've seen deep-seated ageist attitudes towards older people blatantly exposed. We've seen 5 main themes emerging, and I'm just going to run through them now. Firstly, blaming older people. The heightened susceptibility of older people to the virus and specific advice that they self-isolate is sometimes seeing older people blamed for community-wide restrictions. We've all heard of that vulgar hashtag boomer remover, or some kind of expression of the sentiment, we all have to go through this just so that a few old people don't die. Further, much of the messaging of stay inside, wear a mask and so on has instilled a fear and anxiety, a sense of loss in older people. What impact will this have when restrictions are lifted and when we re-emerge into the broader community? How confident will I feel as an older person to be seen out and about? Will I be judged? Will I still be welcome in my community? Another way this is manifesting is calling on older people to take a disproportionate impact of the social but also economic fallout of the pandemic. For example, recently in the budget, measures to assist older workers were seen as less important than measures for younger workers. It's the old pitting generations against each other trope. Secondly, the reporting of age. The highlighting of age in the reporting on deaths from the virus reinforces an underlying view that younger people are not really at risk, so the problem's less serious. Recently, in a blog I wrote called Does Death at Every Age Count? I asked why, when political leaders and media report on a person who's died from COVID-19, they always tell us their age. Why? And critically, what does coupling the news of someone's death with their age signal? Is it to allow a collective but silent sigh of relief because we know older people are more susceptible to the virus and therefore their death is somehow more understandable or expected? Is it because older people are closer to death anyway, so their passing is less lamentable? Is it because older lives are viewed as lesser lives? Are we becoming complacent about the losses because they're mostly older lives? And does the addition of a person's age reinforce an us and them? Does knowing the age of those who die bring us closer together, or does it feed the narrative of the other and drive us apart? So next time you hear of someone who's died from COVID-19 and you hear how old they were, just take a moment and ask yourself, what are they really trying to tell me? Thirdly, language. We know language really, really matters. Language used by the media and spokespeople describing a cohort of people spanning up to 4 decades of life as the elderly entrenches a stereotype that all older people are more or less the same. Now, we know much better than that. We should avoid using sweeping terms like the elderly because they're too broad to be meaningful and they just simply ignore the vast diversity of health and life status. We at Every Age Counts also avoid the term vulnerable, as it reinforces deeply held assumptions that all older people are vulnerable. We use susceptible. Older people may be more susceptible to COVID-19 if there are other comorbidities, but we're all susceptible to this virus. In another troubling development that Rhonda's so articulately explained, we've seen ageist rhetoric dressed up as ethical questions. Don't be fooled, this is a euphemism. This usually turns to discussions about the tolerance for death, tough decisions that have to prioritise one life over another, that strike some sort of number of deaths that are acceptable. Can we really talk about such issues in the abstract without reference to the individual, to my mother, my son, or me, or to our ageist cultural norms? This rhetoric usually flicks these tough questions to political leaders or experts who will somehow magically take into account something called public sentiment. But I hear the warning bells ringing, and I'm sure you do too. We know we live in an ageist society that devalues older people and this stage of our lives, and that we are capable of internalizing it and promulgating it. So I'm not confident that's going to end very, very well. And as Rhonda mentioned, this takes us to the utilitarian world of quality adjusted life years, where the value of the 90-year-old is pitted against the continuing happiness and livelihood of the 25-year-old. Wow, where does one begin to unpack those assumptions? And how would the life of that 25-year-old with a profound disability stack up against the 90-year-old? Or a 45-year-old who's been living a transient life with drug addiction? It reminds me of an ad we have in New South Wales. You may have it in Victoria too, where the interviewer voiceover tells us how many road deaths we have in a year, and then asks a man how many road deaths would be acceptable. The poor guy shrugs his shoulders and says, I don't know, 70 maybe? And then, of course, 70 men, women, and children walk towards him, probably including his own family. And he rethinks his answer and he says, maybe none. Okay, fourthly, an erosion of rights. Here I'd like to spend a few minutes on residential aged care as a quick case study to highlight two forms of ageism we've seen emerge. Firstly, the erosion of rights, and secondly, the lack of voice and agency. In our submission to the Royal Commission on COVID-19, we noted the deeply troubling compromise of the human rights of aged care residents in accessing healthcare on the same terms as those in the broader community. There was somehow an expectation or assumption that a residential aged care facility could transform itself into an acute care setting. Why should it? Aged care and acute care are not the same thing. Placing the responsibility on aged care staff is particularly hard to understand, while hospitals with intensive care units, palliative care capability, highly trained staff, and the capacity for infection management were available. Why and for whom were the hospital beds being saved? Why were aged care residents on a collective basis not deemed suitable for medical treatment in hospitals on an individual basis, which was available to other older people and other ages in the broader community? And why weren't more of us jumping up and down about the assumptions on which those decisions were based? Ageist assumptions and decisions about aged care residents on a collective rather than an individual basis simply does not meet the rights test. Rather, it signals the loss of personhood status and the denial of personal agency to older people in decision-making about their own lives in care situations. And so we have lingering questions. Was the quality and type of healthcare available to those in the broader community restricted or limited for those living in residential aged care? Was free and informed consent sought from residents in aged care to the extent that individuals are able to exercise that right, assisted or independently, regarding medical treatment decisions or even infection control? Did COVID-19 decision-making frameworks in residential aged care incorporate principles and practices to safeguard human dignity, personal agency, and the equality of aged care residents with other Australians? Another deeply troubling feature of the COVID-19 response in aged care is the lack of voice, and this is one of the starkest issues exposed by the pandemic. In particular, we're alarmed that the voices of older people in residential aged care have largely been absent from public debates. This has been the case even on key issues such as visitor policies, resident relocation, and the location of medical treatment of COVID-positive residents. Of course, this was not the case in all facilities, and we acknowledge that the engagement is not simple with residents who are most frail and ill. However, the invisibility of older people in public debates and the absence of evidence from providers or government that residents were being engaged at the local level has deeply concerned us. The absence of older people's voices in public debates about how best to balance safety and well-being is a violation of the sovereignty of older people in the context of care. It is ageism, the infantilizing stereotypes of total vulnerability and dependency in which older people become the object of care and not agents of either individual or collective decision-making. And this entrenches ageist views that older people are totally dependent and that it is appropriate to make decisions for and about them in residential care settings without their active engagements. We must find a way to balance people's risk with their autonomy and agency. And fifthly, the age-based rationing of healthcare. At its worst, we've seen discussions about the possibility and relative merits of age-based rationing of limited healthcare, and suggestions that access to treatment could be based on chronological age. Now, we understand that in crisis situations where there are resource constraints, judgments will need to be made by healthcare practitioners about who receives what. And we acknowledge the extreme pressure that this places on healthcare practitioners, and we are grateful for the role they play on our behalf. But these decisions should be individualised and take into consideration comorbidities, frailty, the capacity to benefit from treatment. This is a complex picture, and age is ever only one factor. Age alone should never be used as the criterion to ration care. Further, when rationing judgments have to be made, decision makers must be aware and conscious of their own ageist prejudices and biases and work against those tendencies in decision making. Snap clinical decisions that are based on ageism need to be interrupted. The human right to healthcare for all must be safeguarded through this pandemic. Older people have the right to be treated fairly and make decisions about their own lives. So, where does that leave us? What can we do? What can I do? Ageism stands exposed now in a way that perhaps it hasn't been before. There is growing awareness, and may I suggest outrage at the deep injustice of this form of prejudice and discrimination. So now we have a historic chance to act, to dismantle ageism, and to ensure that as we emerge from this pandemic, we build a world without ageism. So, of course, as a coalition campaigning for a world without ageism, EveryAGE Counts warmly invites you to join us, sign the pledge, go to our website, use our resources, give your friends a copy of our publication, The Real Old, share the quiz, and so on. But today I want to leave you with 5 simple messages or principles to take into your conversations with your families, your friends, your communities, your members of parliament, your spheres of influence. Firstly, every life is equal, and every human deserves respect and equal access to the right care. The value of life is not age dependent. Secondly, language matters. Listen to how things are framed. Avoid using the term the elderly as a shorthand that lumps together all older people. We are not the same, and age is not a meaningful criterion to describe our great diversity. Thirdly, in any rationing of care scenario, individualized assessment of a person's particular health status is the basis upon which decisions should be made. Age alone should never be used as the criterion to ration care. Clinicians and policymakers, check your ageism at the door. Fourthly, when we see negative messages emerge about older people or about younger people, stand up against ageism and stand for a caring and compassionate society upholding human rights of all. And fifthly, as we emerge from restrictions, we are all welcome back into our communities. We are all valued and we all have a contribution to make. Include older people in recovery planning and stand up for intergenerational solidarity. Thank you for the opportunity to be with you today. I'm really looking forward to our discussion.